All right. Well, good afternoon. My name is Brent Warrick. I am a physician. I'm triple boarded in emergency medicine, medical toxicology, and addiction medicine.
I don't get to
Um,
introduce you, Brandon. I just Snail here.
oh,
I just joined in. I just finished with a patient. Um, you can jump in. Hi everyone, Snail here. Is it okay, Brandon, if I just quickly give you a proper introduction?
sure.
Yeah, so Snail here. Sorry, just came in and logged in. But really happy to have you, Brandon, today to share your expertise. So yeah, for those of you who don't know, Brandon Warrick is a really valued colleague and a really good friend. He's triple boarded in kind of really unique, right? He's triple boarded in emergency medicine, toxicology, and addiction medicine, and practices all three of them. And he actually directs the Poison Center, which many of you guys may have called, right? For patients, or if you're like me when my child ingested some unknown berries. It's a great resource we have in our state, and Brandon directs that. And one of the wonderful things that he has done as part of the New Mexico Emergency Department Bridge program is that he has actually trained all the pharmacists at the Poison Center to be able to answer questions about buprenorphine initiation. So any ER doctor anywhere in the state can call the Poison Control Center and sort of get input or ideas or clinical consultation sort of about questions regarding complicated buprenorphine initiations for patients with opioid use disorder, which I think is a tremendous service to the state. And Brandon, you're the person I turn to, as you know, when questions about urine drug testing come up or novel psychoactive substances come up. And I think your expertise is just valued. So really glad you're here, and feel free to add in if I missed anything. But thank you for presenting.
Oh, you're welcome, and thank you for that introduction. Just a couple of things to clarify is speaking to primarily psychiatry. There's no reason psychiatrists couldn't call needing help with addiction. I'm also happy to start dabbling into some alcohol and long-term care too. If you stump our pharmacists, it's either myself, Eric Ketchum, or Sergio Huerta. That's backup call 24/7. So yeah, give us a call. It doesn't cost you or the patients anything. The patients are also welcome to call. So I'm just going to begin with the talk on designer drugs. We're going to be talking about a little bit of barrier or a little bit of gray lines on what's actually legal and what's actually not. And that line ultimately gets blurred. I choose not to partake in these substances personally, just because I think it's a little too close to a line. And I'm not personally interested in it. But I do find these fascinating in the growth and development. So with that, getting into the objectives, I think we should cover some of the history on how we got to this point, where these drugs are coming from, and why they exist. I also want to talk about some of the recent emerges and changes. This is always a fun talk to give, because as soon as I give it, we're out of date. And going forward, as far as epidemiology, as far as finding and picking this stuff up, in my Adobe Tower of the Poison Center, aka the Project Echo building, I ended up relying a lot on people like you to be able to get samples and identify patients where something didn't go right. And so we'll look to the future. I don't have any relevant financial disclosures on here. I will talk about some treatments that do go outside of the package insert, but I'll explain why we're doing that. None of the there's going to be a brief mention of brand name drugs, but that just simply has to do with counterfeit pills. So with that, I want to begin with one of a case that got me interested in this back when I was in fellowship. So this is a 24-year-old female who ingested 2 of these red capsules at a large concert. She presented to EMS with seizing or generalized shaking and hyperthermic. She had a heart rate of 132, blood pressure was hypotensive, 10 milligrams of diazepam was given in the field. I also have the chat pulled up. So if you guys want to put comments and things in there, I'm happy to try to address some of those comments as they come up. When the patient got to the emergency department, her temperature was 41.8. Obviously, this is too high of a temperature to ever go to psychiatry, in my opinion. This is over 106, about 107 degrees Fahrenheit. A tox-induced fever is a medical emergency, is a true medical emergency that goes with it. I think looking over the rest of the exam, this is fitting as some pathomimetic type picture, or toxidrome, as we call it. More specifically on the neuro exam, the seizure was actually a spontaneous tremor, and the patient had generalized increased muscular tone, bilateral ankle clonus that was more prominent in the lower extremity. So clinically, we'd hope that people on the call or the clinicians would be able to identify this as serotonin syndrome, and arguably, and she's got a fairly severe case of serotonin syndrome that's life-threatening. In the emergency department, she was given IV fluids, and actually a lot of IV fluids. The benzos that she was given in the first 45 minutes is the 10 milligrams pre-hospital diazepam, 2 of lorazepam. And we're going to talk more about that 32 milligrams of midazolam. As a standard of reference, I think most people are comfortable with maybe a 5 milligram dose of midazolam. An intubating dose is 20 milligrams. But we'll talk about how we got to 32 going forward. Patient was packed in ice, was intubated, and their paralytics were used. So the source of the fever in her is just the extreme neuromuscular excitation that had occurred. I think if you think about this, is go running in that really hot day in July out in the sun after work. It's uncomfortable, sure, but getting a fever anywhere near that level is really difficult. And then with the sweating, again, recognition that the patient or physiologic attempts to cool the body off are completely overwhelmed. Hence, we had the fever so high. So the thought behind it is, if we institute a paralytic, can't move and can't generate heat. So over the hospital course, it took about 3 hours to get the fever down, and she would remain afebrile for the rest of her hospital stay. Overnight, she developed epistaxis that required ENT to the bedside to pack it. Complicating it was DIC. For those of you familiar with heat-related injuries, one of the first things that we will see in a heat-related, or in this case of an extreme, is our coagulation pathway forms a DIC type pattern. The morning following this, the patient had a brief PA arrest and had returned to spontaneous circulation. The etiology for the arrest has never been identified, but at that point, she was started on pressors. My theory is that she had just at this point, her catecholamine washout and became hypotensive from that. This is just showing initial versus delayed in the labs. And the column on the left really shows the electrolyte shifts. And I think it's pretty remarkable how big a shifts that occurred in this patient from aggressive saline rehydration. When I speak more to ICU, ER, we talk about a little bit more having physiologic fluids and for reasons like this. The second, and more highlighted on the right side, is the delay in when toxicity is seen. And I think this is really well shown by the INR, where we start off completely normal, as would be predicted, was a young lady in her 20s, and then going off the chart. Her troponin also was a little bit above normal, and then became very abnormal, and her CK as well going up. And just speaking to, by the time the damage has occurred, it oftentimes, our labs often lag behind. On hospital day 2, her hemodynamics and her coagulopathy had improved, but she had developed a very severe case of ARDS and renal failure, despite being in an academic medical center, or had huge challenges being able to oxygenate her adequately. And the parents made, I think, what is the hardest decision in their life, and that was to withdraw the care of their 24-year-old daughter. Knowing something that was amiss or unusual, we did gas chromatography, mass spec. I give John Wilson, who's now retired, tremendous amount of credit. We had both the pill samples as well as our urine, and we're able to identify methylone and butylone. At the time of doing this, what I give John a lot of credit for is being able to help figure out what these molecules looked like based on their mass spec readout, order the controls, so we could actively do that. And we'll make mention of this. We're going to come back to this case a couple of times in the talk. One is one of the areas is in terms of what type of testing that we do and what type of testing is available. What Dr. Wilson was doing is what we call non-targeted testing, meaning that we're gonna, if we see a compound, we see something coming off the column, we want to be able to identify it and know that it's there. Most basically, if it's CLIA, which means that any normal lab will have a menu on a test, and if these drugs are new and not on the menu, it won't show up there. So I always think of, where do we begin as a story of designer drugs, and do we go back to the very beginning of human beings using drugs for a mind-altering effect? But I think really the Shulgins really are I think my favorite place to start. Academically, I have aspirations of publishing like Shulgin, but I know I'll never even come close. His CV is an impressive one. So after graduating from Harvard, World War II was in swing. He joined the military, served his time in the Pacific Theater, came back, got a doctorate degree at UC Berkeley in chemistry. While there, he experimented with the plant native to New Mexico in the upper right corner, which is peyote, and the active ingredient is muscarine, and it's an hallucinogenic. Well, he hypothesized that he could synthesize and figure out how to make muscarine, and it's probably a better way, because I also want to make note that peyote is an endangered species, and so destruction and destroying it is illegal under federal law. So he was able to synthesize muscarine and peyote and experimented on himself and others. Following graduation, he took a job with a chemical and made one of the first biodegradable pesticides. Just as we see with like the big tech companies, Microsoft, Google, Apple, if you intellectually make major contributions to the company, they recognize your intellectual gift. They give you more freedom, more space to kind of experiment, to do things that you want. Part of this is also understanding the timing of this. This is now in the late 50s, or this is in the 50s and the 1960s, when understanding neuroreceptors was at its true infancy. And what Shulgin and his followers did is, by studying these compounds on themselves, he subjectively knew exactly what serotonin, he knew what dopamine felt like. He knew just subjectively which different serotonin receptors things were hitting and antagonizing. And so with the coming of age of neuroreceptors and understanding that, he's able to advance science very quickly. For Snehal and I, we enjoy doing research together, and on a project that we're working on. We're on a 5-year NIH clinical trial. Thank you, and by the way, thank you for including me in that, Snehal. That it's going to take 6 years to get results from and a publication, a result from that study. What these guys can do is, hey, it's Friday afternoon, and say, like, they geek out in the chemistry lab after classes on Friday, and they do a synthesis and say they need to finish it up Saturday because part of the reaction needs to sit overnight. And then they experiment on themselves Saturday night and into Sunday. They're writing up the results of their test and are back to work Monday morning. And so again, in a day and age now with IRB and the modern ethics, we just can't compete with it. So as Shulgin was getting into a lot of this, industry kind of came to him and said, we just don't see a future and we're not sure we agree with this. So he basically moved his lab into the shed of the backyard of his Berkeley home, where he would work as a chemist for the rest of his life. He had the equivalent of multiple postdoc fellows, including at least one full professor here from UNM who spent time studying with him. And he's got his students that have studied with him that have gone all over the country. Some of his major accomplishments, he's got at least 6 or 7 publications in the journal Nature within a decade. I know of no other researcher that has even come close to that benchmark. He's had well over 1,000 peer-reviewed publications that have come out, including publications coming out post after his death for more than a year or two. He died of complications with stroke in '94, and I don't think we're ever going to have anybody quite like him in the future. So some of the things that Shulgin did, and I want to kind of impress you, is he has got this cult-like following. So this is Hamilton Morris. So if you're bored this weekend or you're looking for the next thing to binge on Vice Network, there's Hamilton's Pharmacopoeia, where he goes through different psychoactive substances, and more not like the straight up methamphetamine, cocaine, marijuana, but more of the hallucinogens and the less common, goes around the world reporting on it. And he starts off one of Shulgin's last interviews that I love Alexander Shulgin. I've loved him from the moment I read about him. He is my idol, my hero, my son, my O2. Like, I know Valentine's Day is coming, but this would be pretty, this is like, I almost want to steal this to put on a Valentine's Day card to my sweetheart. But, you know, if I put on my O2, that almost just kind of crosses a little bit different than a typical Valentine's Day card. So this is a book that he made or wrote, is PCOL. It's an acronym for phenethylamines that I've been known and loved. I'm going to define what a phenethylamine is here shortly. But this was published in 1991. He had 179 chemicals that describe the synthesis and the subjective effects of it. And again, if you want to take a look at this and you get bored with my talk, I'm all about like going online and finding the free copy of it. If you really like my work and you're looking for a gift for me, I would love a signed copy of this by Shulgin. Last time I looked on eBay, these were going for getting close to $500 a copy. Most of these copies continue to be, most of these compounds continue to be legal today. And like I said, you can get a free copy at Arrowhead. So here we're going to go to probably the scariest place that I could take a physician at this point, and that's going to be back to organic chemistry. But it's okay. You're going to come with me, and we're going to need to look at some chemical structures. And when you do this, take a look, or I want your approach to be like a art history class. We're looking for a pattern. There's no test at the end of this, and I'm not going to ask you, but I want you to look at those pattern recognitions. And the pattern on how that works is going to dictate its function. Also, when we start thinking about how does that common urine drug screen work on a patient's urine that we get, again, it's an antibody looking for a molecule. So we're looking for those similarities. So we're going to start with something very easy. This is phenethylamine. As I said, I was going to define it. And it gets its name by, we have the benzene or the phenyl ring with 2 carbons, ethyl, and amine, having the nitrogen base. Phenethylamine does not have any function in the body just because it's broken down so fast and not important. Now, if we start making changes on the phenyl or the ring portion, we start looking like this molecule serotonin. If we start making changes on the amine portion, we start looking like dopamine. At this point, I would hope that most of the psych faculty is very well aware these are two very important neurotransmitters, and most notably, they're what makes us feel good, what makes us happy, what gives us our emotion. And so mimicking those two molecules makes sense. So Hamilton Morris goes on and riddles the question, how many numbers are to the right of the decimal point in pi? Nearly an infinite number. I know we have March 14th, just about a month away, so I don't get any further than March 14th on Pi Day, but some people want to recite as many numbers. That's just a reminder to begin practicing. Everywhere where there's an R group here, that's a new or a different compound by changing that up. Snehal put in a very fascinating category of substances in his opinion, acting as a stimulant and a psychedelic. Yeah, and I think that's 100% agree. And your timing is perfect because we're going to talk about just that. So remember I said phenethylamine really doesn't last in the body. So let's start with something that we know is amphetamine. So it's basically phenethylamine with a methyl group at that alpha carbon. And you'll notice that alpha carbon is also chiral. Remember, chiral is right and left hand. Our hands look the same, but when you put the left hand glove on the right hand, it just doesn't fit. Same thing here, and we'll see that with the D enantiomer as being the far more active. This is just giving you norepinephrine for comparison. Now, if we add a methyl group onto the amine from amphetamine, we make methamphetamine. Adding two oxygens in a methyl group from methamphetamine, we get MDMA. And if you're like me, you could never remember that big long name of methylene dioxymethamphetamine until you saw the structure of MDMA, and then it all of a sudden starts making sense. Also, remember when I go back to that structure-function relationship, amphetamine and methamphetamine really are a lot more on the dopaminergic. They're on that adrenaline side of life. When we start making the jump to MDMA, we really hit serotonin a lot harder. When we start comparing the Truon psych hallucinogens like peyote or muscarine, MDMA has a lot more stimulant properties because of the methamphetamine structure. Because we live in New Mexico, I also think if I haven't made this clear, I want to bring pseudoephedrine on board. So pseudoephedrine is methamphetamine with an hydroxyl group on the beta carbon. I know you all had to take organic chemistry, and I'm sorry, I didn't have anything to do with that, but I would hope that you would recognize that if we could do a simple hydrolysis reaction, we go from making pseudoephedrine to making methamphetamine. Now, when you watch the pilot episode or that first episode of Breaking Bad, the reason why Vince Gilligan and the crew made pseudoephedrine or making meth much more complicated is because, remember, the end product was a very high purity. And so a lot of the steps that went into that is to having a very high grade of the pseudoephedrine, doing the reaction, and then separating out everything on the back end. Because remember, there's that candy coating, there's the starches, the conjugates that hold everything together. Nevertheless, that was a digression, but I would hope at this point you can start seeing that pseudoephedrine and methamphetamine are biologically very different, yet structurally very similar, and how small changes in these groups make a difference. So kind of going over this and how does this new generation of designer drugs work, and where do we come up with this? So I've got phenethylamine up here, we've got MDMA, methamphetamine, and I'm introducing cathinone for the first time. So cathinone is naturally occurring in a plant called khat that grows in the Horn of Africa or the Arabian Peninsula. And historically, for thousands of years, people have chewed on the leaves of the khat plant for its stimulatory properties. Now, remember on our first case, our patient had ingested methadone, and I showed you the chemical structure, and I'm just showing it again here, is basically when, whoops, I don't know how I just did that with the Zoom, I'm sorry. Oh, there we go. With methadone, hey, this is just MDMA and they put a ketone on it. Gee, that all of a sudden, the brilliance of where they came up with it just doesn't seem to be as exciting. I'm putting bupropion on here. I think, again, within Department of Psychiatry, this is a very common drug. And as far as FDA-approved medications, there's wide application from depression to smoking cessation to weight loss, so many things that it does. And it is an FDA-approved cathinone. I put methylphenidate here on the bottom just to kind of start giving you an idea of different variations. Now, chemists generally don't consider methylphenidate to be a phenethylamine. And giving this on the PowerPoint, it's hard because I don't have a pointer, but you're seeing the phenyl ring, 2 carbons linking to the nitrogen, and then another 6-membered ring coming around. And so we still have that phenethylamine at a core, but other significant changes. So these are just some of the common or more common cathinones that have emerged coming out. This is one of my more favorite ones, drug bromo dragonfly. And when you see the chemical structure, the name all of a sudden makes sense and all of a sudden fits. And you guessed it, it's very much of a hallucinogen and hits serotonin pretty hard. So more coming to more recent times in the present, in 2011, Shulgin published the Shulgin Index describing 1,300 compounds, most are legal. I'm not sure where you get your book reports from, but this is the most helpful report on Amazon. And it's not like most book reports on Amazon, but written by Nothing is the name of the author. And he writes, or she writes, Alexander Shulgin has done more for humankind than any other in the history of ourselves. He is getting very old, and I believe this is his last true effort to inform, educate, and help people truly understand these chemicals and how they should be used. A most invaluable source, never to be printed again. Buy it, learn it, read from it, take more drugs. Thank you. Having this book on my bookshelf, the work reference section is nearly 100 pages long alone. And I don't see this ever, I don't see anything like this ever be printed again. I was just seeing if anybody caught that this was just volume 1. So his next book was Tryptamines I've been known and loved. I don't have time, and basically we've taken the molecules serotonin and how many changes can we make. I don't have time to go through all of these compounds, but maybe on another day. We have the simple plant isoquinones. I think this one's interesting. So LSA is naturally occurring. The plant with the highest concentration is Hawaiian baby rosewood, but most commonly is going to be morning glory seeds. One of my former rotators, and I've got a picture of him coming up, we were going through on this talk, and he got inspired to order a whole bunch of heavenly blue morning glory seeds off of Amazon. And the shipment never got to him. Evidently, the feds intercepted it. But it's not for the reason that you think. The reason it got intercepted was it came from China, and U.S. Department of Agriculture didn't take well to bring seeds across the border, just like when you try to bring that apple across the border from Canada. But LSD is currently a Schedule 1, and I think going forward, I think there is a question from the FDA: is there medicinal value into LSD? And that's ultimately for the FDA to figure out with DEA. So bath salts to me are a little bit in the rearview mirror, but they do this with their name, and this is not because this is what I'm going to get my significant other for Valentine's Day coming up. This is more on compounds in these little small packaging. I think my significant other might be upset if we only gave her 500 milligrams for take a bath in. But I also am always amazed by the creativity with their writing and everything. One of the things that tends to be very common in this is this comment of not for human consumption. And that's really to circumvent the analog drug law. All right. I'm just looking at over the question in the comment, and I think it's a really good one. That comment I want to save until the end, and I would also welcome Dr. Bott to provide some input on that too. But I want to make sure we'll make sure we've got time to address that. Basically, when this is the largest study done on looking at bath salts to date, and I think my take homes of this and being the first author on the paper was, this is people trying to have a mind altering experience without going to jail. And I think with new compounds, new drugs, without knowing what a dose is, knowing what an experience is going to be, and putting things in like 500 milligrams in a packet, when that's too high of a dose, I think it was no surprise. And I think from a harm reduction standpoint, I particularly worry about necessarily inventing new and different compounds. During the time when we did the study, the marijuana homologs, the K2 spices, and we'll talk about them briefly, were all legal. And that's the other thing that people were using. I think there's some serious underreporting. An alcohol and a marijuana rate of less than 1 in 10. I think at least 1 in 10 of my patients showing up in the ER has it, much less into a designer drug. As far as medical outcomes and the severity, this is using poison center definition. So basically a major effect, in a little more complicated, but in simplest terms is they were intubated or needed an ICU level admission. And you'll notice an intubation rate of 8.7%. I know when we submitted the paper, one of the comments that came back is, wow, your intubation and your major effect rate is really high compared to anything that we would see from any other stimulant. And our answer was, yeah, we could have some bias in our results, but I think it also speaks to the level of danger that untested or brand new compounds are to the masses. Also noticing that benzodiazepines are the #1 use of treatment, and with a distant second of antipsychotics. We did this paper got a best poster at the American Chemical Society, and we basically obtained a lot of these compounds. I see Susan Smolinski's on. She was my partner in crime in ordering this stuff off the internet, and it was always one of my favorite all-time projects that I've done with her over our 13 plus years of working together. And it's coming to an end as she's retiring. So we identified several different compounds, notably lidocaine, and we're going to come into what are those other things, what else are they adding to it? Lidocaine continues to be added. A lot of these other things are just alphabet soup, but understand what they're doing is they're fishing for or trying to figure out what people want and reorder and what's going to be the next drug of abuse. They know that law enforcement is on their heels and they maintain one step ahead. As far as treatment goes, I think these patients present a clear and present danger to themselves and as well as staff. Agitation and hallucination are very high and predominant here. And this is a patient population. Let's just say you don't come to the hospital if you're having a good trip. I think a lot of these patients too are probably at a good, may need a higher level of care than what we can safely do at PES. And I'll state once again to anybody and everybody who's listening, I really wished in the new hospital that we could have our psych ER right next to our main ER. When I was in Detroit, having the two right next to each other solved so many problems. And just being up the road at Marble, I know it's close, but I think we know the limitations of monitoring some of these people up there. I think it's to understand a lot of the physiologic effects come from high level of stimulation in norepinephrine, serotonin and dopamine. So the treatment really for me and in my mind is I want to hyperpolarize the brain. And I do that with benzos. This is what I affectionately refer to the benzo hammer. There is no maximum dose. It's what you feel comfortable with. Again, this isn't something that I would feel comfortable doing in PES. I would be looking to get the patient over to UNMH in the ER where we can do this. Pick your benzo that's your favorite. I like midazolam just because it's shorter acting. It's very fast acting, being highly lipid soluble, and I can give it IM inhalation or IV. And I think it's important that I really don't like having my staff start an IV on somebody who's thrashing around in the bed. I think that's just a safety risk. I tend to double the dose every 10 to 15 minutes because that's when we would see respiratory depression. Over the years, having done this countless times, the only times when I've ever had problems with needing with respiratory depression is when there's a co-occurring opioid on board, and I usually just give a touch or a smell, a whiff, almost down to the homeopathic dose of naloxone, and the patient generally does well, and titrate it to get them calm. Again, I don't expect you to do this in the ER, or I'm sorry, in PES. And if you want to use an antipsychotic, I tend to use haloperidol or risperidone. Just haloperidol is just so sedating, and we have so many years of experience with it. And risperidone, I always like it just because it doesn't have a big effect on the QT. This is Dave Horn. He is one of my best residents that I've ever worked with. He's now multi-boarded and faculty further west of here. But this is about 100 milligrams of midazolam and a gram of phenobarb that we gave to a patient. And because I know you're all asking, is no, we did not intubate the patient. Just saying, hey, I've been here, done that. But I also have, in speaking for Steve McLaughlin, who's the CMO of the hospital, I think when you're starting to get much outside the package inserts, Dr. McLaughlin would definitely want the poison, or definitely wants us on board with a poison center on those cases. So we're going to have you recharge with your bath salt, and you'll notice that your bath is to last 1 to 3 hours and not for human consumption. Without some alcohol or a bunch of friends in a bathtub, I'm not sure who really takes a bath for 1 to 3 hours, unless the kids are locked in outside and you're having some quiet time. All right, so this is getting into some herbal blends and the K2, the spice. So marijuana or cannabis is traditionally smoked. And so basically what they do is they put the compound on dried plant material. The plant material can be anything and everything under the sun, and then put in here. And these continue to make news. This is a story that I think is, when you're making headlines on a bunch of people going to the hospital, is just fun. The evolution of the synthetic cannabinoids, it has been really aggressive and very quick. More than have it in a potency or an measured by EC50 has gotten over 100 times more potent in a 5-6 year period of time. And if I were to continue this out to current day, we're going to see it even more potent. With that, we are also seeing with these new synthetic cannabinoids, very high rates of seizures. Having a seizure at 40% is higher than basically any other drug in frequency. And at the number one drug-induced seizure in the United States is bupropion. And I can tell you, bupropion ingestions, I'm not at a 40%. And I think this is interesting because we also have cannabidiol that's now FDA approved for treatment of refractory seizures, so giving complexity to how our endocannabinoid system works. The only true zombie outbreak ever to be reported in human literature is from AMB Fuminaca, a synthetic cannabinoid, and it was in New England Journal of Medicine. I'm going to make it with two of the authors, Jordan Trekkie and Roy Girona. I'm going to pull them out on another project here in a little bit that we're invited to take part of. Oh, and you can't beat the name of the compound is AK-47 24 karat gold, especially given assault rifle ban that just is working itself through the roundhouse as we speak. The reason for this getting the nod to New England is this huge interdepartmental people working together and to stem this one outbreak. And I think when you start thinking about how much effort goes into this single outbreak to stop the sale of this, I think it's pretty labor intensive. And knowing that people are one step ahead, it's kind of frustrating in the back end. This is getting into the synthetic opioids. So we pretty much looked at just two-dimensional structures. And what I'm trying to identify is how fentanyl, when it's folded into a three-dimensional structure, starts more looking like morphine. These are some of the fentanyl derivatives that have emerged. I think fentanyl is well suited for going forward. Now that our supply of fentanyl is coming from south of the border, and the cartels have really taken over the bulk of this, the cartels just don't seem to be all that interested in the newest and latest greatest compound. And there have been over 10,000 different proposed analogs of fentanyl alone. And so we're seeing these put into counterfeit pills. My patients in the addiction clinic are all struggle to find heroin. And unless Bot or Romo, one of the addiction people on, has seen somebody been able to get that's heroin in the last year, I would be surprised, but my patients they cannot find it. We are also in an era of the designer benzodiazepines. I've had multiple healthcare providers, and you're still able to do a good old-fashioned Google search and find designer benzos online and for sale. Healthcare people tend to go with what they know, and these are a little bit different and going. They're definitely out there. They're definitely in the state too. This was just in preparing the talk, one of the top website on Google that we had. And just so you know, I've been doing these searches for years before DA ever reached out to me. Now DA likes to meet with me, so I get to go meet with them Monday afternoon. Brought Snehal once too, and it's really a kind of a fun work group that we have working together on some of this stuff. So this is going to transition into, we've talked about some of the drugs, and I want to transition into what are they mixing the drugs with. Xylazine is one that has, at this time, I've just in the last year, 2 years, had at least 3 reports in MMWR. Outside of COVID or an infectious disease, let's just say MMWR doesn't pick up on drugs of abuse very often. And when they do, it's just not as frequent. And to have 3 different reports is unusual. So xylazine is an alpha-2 agonist. Think like clonidine, think dexmedetomidine. And while it's FDA approved, the scope is limited to veterinary use only, and that's in our drug supply. There was some question in a couple of cases that suggested in the fall of 2022 that xylazine had found its way to New Mexico, but over the last 2-3 months, I have not had any additional cases that people are suspecting it to. Nevertheless, the coast, especially on the East Coast, they're seeing this regularly, and it's just a matter of time before it finds its way into our drug supply here. So I think those patients who are more hypotensive, bradycardic, more sedated from an opioid than you would expect, those might be those xylazine cases. This is another interesting. So we had the synthetic cannabinoid outbreak, and in this, there was a long-acting vitamin K antagonist, brudifacone. We use that as, or used to use that as rat poisoning, and I use the word used because industry's kind of moved on to safer things. But with that, the amount of vitamin K used to treat this epidemic essentially drained the entire stock supply. The levamisole continues to be in our cocaine supply. And this was my first paper with the New Mexico Department of Health. And this was before I was in here. We wrote that, and we're continuing to see this today. We also have these skin lesions that occur, and this is a vasculitis, and this is I took from the rheumatology literature. I've had a few cases like this. My cases, my worst one, lady lost her nose, ears, and bilateral leg amputations, multiple digits on her fingers, and there is no treatment for that. So there's your scary skin thing. Recently, in the last quarter of 2022, quinine started showing up for the first time. And just as a couple of treatment things, and a quinine is, we're going to screen for that on EKG because it's a sodium channel blockade, looking for QRS prolongation, treat with sodium bicarb. I'm also very aggressive with multi-dose charcoal. I've got 5 drugs that I have strong feelings on multi-dose charcoal where it works well. Quinidine or quinine is one of them. We have the N-bomb series. These are probably the most hallucinogenic compounds known here at this point. Is synthetic cocaines, our PCP analogs. These are ones that have more emerged. So I think what's next is it's ultimately up to the chemists. There's sites like Arrowhead that I think that are, while I've never done any peer review for them, that these are written by Earth, and they go by Earth and Fire Arrowhead. They actually do publish in real scientific real high-end scholarly scientific journals. They're very knowledgeable, very experienced in this, and they have hundreds of different compounds and descriptions of them. This is a program, the DEA Tox. So I said I was going to talk about Roy Gerona and Jordan Trekkie. So this is a project that I have now put together, and it's taken a few years, a standard operating procedure with Tricor Lab. So if this would go de-identified to UCSF to do non-targeted testing to try to figure out what's in the drug supply in New Mexico, because Tricor is very limited in what they can do compared to a reference lab. With that said, I think they do a great job. They just don't have the volume of all these new and different things. You can involve me in that care, and we can help with that. But basically, we're once a month sending some of these shipments to the DEA Tox. And the easiest way I do to find their website, and Jordan Trekkie is the PI on this, is to just Google DEA Tox, and it comes up right away. Other places that you can go is the chat forums. So this is, remember I said we would come back to that first case that we started with, and that here what's happening is they go through the peer-reviewed literature and they look at different cases, things that they find interesting, and then they talk about it. This brings letters to the editor to a whole new level. I'm not super, what an asshole to put so much in a cap, or I'm angry face. I'm not super surprised. But just like anywhere, then you have trolls. And so Herbal Jaw writes, if hospitals had more knowledgeable doctors and nurses, they would have saved her life for sure. They probably gave her something stupid like 2 milligrams of Valium IV. They should have hit her with 30 to 45 milligrams of Ativan and some of that shit that works like Narcan, but for benzos on hand, just in case. Word. Wow, that's almost unintelligible that I'm struggling to get through it. And spelling word with a 0, like, how can you there's just, how do you not get reacted out of it? So, but I think people who know me, that I try not to take things for granted when I start breaking this down, Herbal Jot has some reasonable sense for medical knowledge and recognizing that benzos are first line therapy and that we're going to need that we in medicine typically underdose and that we should give them a lot. I think I use the pronoun he because I don't know, to me this is written more like a dude being a jerk than a woman, but I could be sexist there. But I think recognition that we need to use really high doses. When I look back at the dose that we used on the patient, we actually ran right into this case. Obviously, we don't use flumazenil, or I think in my clinical practice, I can count on my 10 little fingers the number of times that I've given it. And it's been years since the last time. This is just kind of going over the Analog Drug Law Act of 1986. Is there some very vague terminology that is used to circumvent it? And I think part of the challenge is that the classes of drugs that we've talked about, there isn't a physician that doesn't prescribe something that isn't in like this phenethylamine class, going from decongestants to antidepressants to our treating Parkinson's or ICU drugs. It's just huge. So I think be suspicious when somebody's using something that's unusual, the presentation doesn't look right. I think we need our antenna up. Give us a call at the Poison Center and we can help you get some of this tested so that we can know what's in it. And I use that to help you guys in our audience and going forward. With that, I want to go through and look at the questions. All right.
Hi, Dr. Warrick, there's a couple of questions in chat.
Yeah. So the big question was, and I want to thank Christopher for this, what are the indications for unguided higher level testing, GCMS for intoxicants? So that's going to be going into the DEA talks. DEA just wants to make sure we're not having 1,001 heroin samples being nothing but heroin. I think if a patient reports a different feeling or an unusual feeling or an experience that was quite different than what they are used to getting, to me, that's a bit of a red flag, and that's something that I would be interested in. A lot of these patients are very, how should I say, they're experienced with their drug or their limited drug or class or selection. Next question is, recently had a very experienced stimulant user and it was unexpected and significant supportive care. I would agree with that. I also agree with that I trained in Detroit and that our designer drugs aren't nearly as in vogue as what they are out on the East Coast. I agree with that too. Yeah, and I think I got your last question too. The other lab that I use a lot is NMS Labs. They're in one of the Philly suburbs, and they have what they call their expanded panel, and that tests. I think I haven't done a count recently because they keep adding to it. I know it's well over 200 and probably around 250 different compounds as well.
And Snail here, I think one of the other, thank you, Dr. Warrick, that was a great presentation, right? And like part of that question is also like, what's the value? Because very oftentimes we have no idea when the patient presents to the ED or to psychiatric emergency services, what substance may have been, taken, and we're often providing supportive care, presumptive care. Like at what point does knowing what the substance is become indicated, right? And I think my sense of it is, Dr. Warrick, that certainly with a prolonged stay, but very often oftentimes the stays are not that long. Certainly with synthetic cannabinoids, the average ER stays are not, the results wouldn't be back by the time the patient is discharged. But I think that can often give us a very important clue as to what the local trends are. And you touched upon that, Dr. Warrick, right? That through testing, so if we see something unusual and if you're able to test for it, we can go, oh my gosh, this is in our community. And also these partnerships between the healthcare providers, between the Department of Health, between the DEA, and if everyone's sort of talking, then that allows us to be prepared before these things really start to kind of really impact the community, I suppose. That's sort of my sense of it, Dr. Brandon. What are your thoughts?
I wholeheartedly agree. I think it's not going to change management for that individual patient, but I think goes back to one of my objectives on the epidemiology here. We need these cases. Our drug supply is changing. We've seen a massive. If you would have asked me before the pandemic, how often are we seeing fentanyl? I would have said rarely. We've got a heroin problem here, and our heroin in a year or two is basically just disappeared and replaced by fentanyl. And then, like we said, we had, our levamisole continues to show up. In there, we have now quinine, xylazine. It's a matter of time before that arrives here. And I think all that is, if we have that information, knowledge is power, and sharing that through Department of Health with HON alerts, et cetera, get that message out. So it might not help the patient in front of you today, but long-term, it's going to help another patient out from a public health standpoint.
Yeah, and those trends are so region specific, right? To the point that was made, in the question by you. Like a lot of my colleagues, I was actually talking to a really close colleague in on the East Coast yesterday, and they're seeing a whole lot of actually, kind of the synthetic dissociatives, like 4-MeO-PCP specifically, and they're seeing a bunch of it, and I haven't really at least come across that here at ASAP. So I also agree that we often tend to be kind of a little bit, behind the national trends with these. And there was another question in chat, Brandon, from Dr. Delmore. How would you best advise young adults to experiment responsibly if they're going to try taking pills, even if you tell them not to?
That's always a great question. But my advice to them is really follow what Shulgin does and what he did learning the hard way. Start low and go up very, very slowly on doses, and to know that your first dose, you probably should not feel anything at all, and then just slowly work up to a dose that you're satisfied with. I'm a firm believer that you shouldn't use alone either, that if there's a particular problem, you want somebody who is in a correct mindset that can seek help. I also think if you're around people who use these compounds on a regular basis, they can help you through, for lack of a better term, a spiritual crisis, as things go too, and help talk and guide people through that. And I think, like with Dr. Bott's work with psychedelics for treatment of alcohol use disorder, we've got two therapists there for the entire time that can help help the person get through the experience in a safe way. Those would be the directions that I would recommend.
And Stanley, if I may add something, there's some good public domain stuff also out there. I mean, I think one that, I think it's for older, right? Like teenagers and kind of young adults who are thinking about experimenting. Something like the Zendo project has some harm reduction stuff, that's also available on the internet. And they maintain a presence at like Burning Man and things like that for, providing support with that.
Yeah, and with Burning Man, there's a spiritual crisis tent and a whole team where they have people who help guide you through your bad or rough experience, and they actually have some really good results. Having never been to Burning Man, but that if I ever go, that's on my list of things to be able to do or to be able to observe. how they're doing that. All right, with that, I want to be respectful of everybody's time. We're at that 2 o'clock hour. I want to thank everybody for tuning in. If that's still a thing in 2023, and thank you for your participation and your help.
Thank you so much.